So this means that colorectal cancer is a social problem, very frequent, increases with age after 50, and can be lethal, but we can prevent. So why not doing this? This is the first cultural and political questions that we have to keep in mind. Of course, not all polyps are dangerous. Adenomatous polyps are more dangerous. We can detect these by biopsy and treat them. They also increase with age, and also when they are large, the risk is increased. And you have seen this sequence that small polyp grows into large, dysplasia, and cancer. But this can require 10 years. So we have time to detect small polyps. Sometimes they are depressed, but we can still detect by colonoscopy. So what are the recommendations? You have heard something. We can use screening in an effective way. The screening can decrease mortality, and these are young people that we can save. We have usual risk patients and high-risk patients. So even at the level of family doctors, it's very important to keep in mind that everybody at the age of 50 should start the screening. In Italy, United States, in Romania is the same. And also, we should keep this screening going on for many years until there is a reasonable old age, 75 or maybe 85 years, and then we can stop. And also, we have to discuss in which way we want to prevent the cancer, which methods we have, what is the preference of the patient. Those at increased risk need more follow-up, and we need a history, and this can be done at the level of family doctor, genetic predisposition, relatives, and other degrees, and inflammatory bowel disease. So we had all these in mind when we started in Apulia. There are increased risk, you heard this before, and decreased risk, you see, selenium, consumption of antioxidants and fibers. Also, few simple questions can detect subjects and can save lives. Have you ever had colorectal cancer? No. Have you had inflammatory bowel? No. Have you family members colorectal cancer or polyps? No. If which kind of degrees, if yes. And if there is one yes, we need to detect more in these subjects. Colonoscopy is important. Double contrast barium enema sometimes can give diagnostics instead of colonoscopy. Virtual colonoscopy still has to be put in place because we don't know, it can be expensive at the moment. And all societies, Professor Dumitrescu said this, only colonoscopy, pancolonoscopy can be done every 10 years in a safe way. All the other techniques, barium, sigmoidoscopy, CT scan, every 5 years. These are important to detect polyps and cancer. But to prevent, to see primarily to detect cancer, then we can use other tests, and fecal occult blood test is the most important. So there is a strong evidence that screening reduces mortality, but we know that screening are very low in every country, and in the United States only 60% of adults over 50 years received appropriate screening. Why is it so? We have different fecal occult blood tests. The standard guaiac-based test must be repeated 3 times. And the patient can do this, but sometimes is bored. It is effective in all screening programs. It's cheap. We have a more specific test, immunochemical test for fecal blood. This is specific for globin, so we can rule out upper bleeding, can believe that it's from colon. Can be more expensive than the standard guaiac test, but if we have a better diagnostic, maybe less colonoscopies will be needed, and then we can save money. And guidelines suggest that these tests should be performed every year after 45, 50 years, instead of before colonoscopy. So we have some initial experience from Sofar with this Prevent ID. This is a new test because we can detect upper blood from lower blood. And from this reaction, we can say there's upper bleeding or a probability of lower bleeding or both. And we can report here our initial 30 patients screened, 24 were negative for upper-lower bleeding. They had some lesions, but they were not bleeding at that time. But 6 positive patients, most of them, apart from these false positive, but